This is Tom Lee, editor-in-chief of NEJM Catalyst, and today we're talking to Edwina Bhaskaran. She is Mayo Clinic's very first Chief Clinical Systems and Informatics Officer. I'm always interested in chatting with people who are the first in a new role because that suggests there's a problem that the traditional organizational structure was not set up to solve. And the people who are the first ones into roles are usually interesting thinkers and problem solvers, since no one else has been able to address the issues in the past. When I first met Edwina, which was in November of 2024, she told me what her responsibilities were, but it really became clear for me that she was doing interesting work when I said to her, "What's the problem you're trying to solve?" And she told me it was really to speed the adoption of IT innovations that would make care better. That seemed like something interesting to me, and she agreed that we would have a conversation and share some of her insights with all of you. So first, Edwina, let me start by asking you a bit about your background and how you came to focus on this interesting challenge.
Yes, thank you so much. It was nice to hear that introduction and be reminded of how we met, Dr. Lee. It was a good conversation that we both had. So yes, my experience is varied. It has spanned across health systems. It's gone international. It's led me to very interesting places and parts of the world, leading greenfield hospitals, as well as now joining the organization of Mayo Clinic, which has been an incredible honor and privilege to serve in the role that I have right now. But as I've worked across clinical care, systems leadership, technology over the past 2 decades, it has really struck me in terms of looking at people, process, and technology, the people side of it. And so the role that I currently have speaks on behalf of our Mayo Clinic practice in advocating for clinical systems that meets the needs of our clinical caregivers at the bedside, at the point of care, and also even beyond in terms of as we're looking for solutions outside of our walls and into solutions in the home, et cetera. And it's always fascinated me thinking about, as we roll out technology, what makes certain technology that indispensable partner in clinical care, if you will, and what technology perhaps doesn't necessarily make the cut. And how do we figure out where that line is and what technology should we perhaps say, this isn't really working for us and why? And perhaps looking at the other side of the coin to say, this technology really works for our organization, and how do we learn from that in terms of looking at other technologies that we're adopting?
Well, I was drawn to you right away because I could tell you were more of a people expert than an IT expert, even though you know a lot about IT. So let's start with a few examples of the challenges. And let's start with something that might not sound so glamorous, but as you taught me, it's really important. How to accelerate adoption of the features and functions of incremental change through software upgrade. And, let's use electronic health records as an example. Can you tell us why this example seems important to you?
Yes, as we look at electronic health records as the example, most organizations at this point have years, decades even, of experience in maintaining these systems. And most of these systems run off of incremental change that happens in various forms. It can happen in vendor-provided software upgrades. It can also happen through incremental optimization and enhancements that we're doing based off of feedback that we've gotten from our clinicians and end users. And several of those technology enhancements come at our clinicians almost in a rapid manner. Our organization, as an example, we take on quarterly updates, and those quarterly updates can have hundreds of changes. Not all of those changes apply to every single clinician, but we still have a very high volume of change that's happening to our systems on an ongoing basis. And some of those changes are really changes that are making the practice run and operate. And so they naturally, intrinsically fall into workflow and they're adopted. There's other changes sometimes that were thought of either kind of in the boardroom, we thought this was a good idea, or in a executive meeting for clinical systems leadership, et cetera. And then when it gets to the bedside, it just doesn't stick. And so when we think about those types of examples and we think about the incremental changes that those do, we've heard the expression of, looking at the pebbles in the shoe and meeting those changes and challenges at the moment of this is actually a pebble in the shoe versus this is a perceived pebble in the shoe, and trying to figure out where that lies is very important. So a couple of examples that comes to my mind is we recently introduced flow sheet macros as an example of changes that we made from a feature set perspective. And we had varying degrees of success when it came out of the box. In some units, we found that there was increased adoption. In some units, we found that there weren't the same level of adoption. And when you start to examine why that is, there's multi-factors. Some, it is the way in which the feature is designed to the workflow of the said unit. It may not lend itself well to perhaps a critical care unit versus a general inpatient unit, as an example. In some other cases, it might be a symptom of, well, culturally, do we have perhaps one or two individuals that are really looking at this tool and saying this is, and embracing it and teaching others? And we could also have the reverse happen, where we have an influential user who's saying, yeah, this doesn't really fit in our workflow. So thinking about it from a workflow perspective, a culture perspective, is it actually fitting a need? Is it solving a problem that we currently have? Usually is at the root of those problems in terms of looking at it. It's still also a very healthy balance of trying to figure out how many of these changes our organizational end users can adopt at any given time.
Well, maybe you can give an example or two, or generalize a bit about if features actually save clinicians time, why don't clinicians just adopt them? And then how do you address their concerns? And is it working?
Yeah, I think some of that in terms of the rationale for why don't they just adopt it if it saves time? It does. It's rooted in muscle memory at this point. There's a lot of muscle memory as I talk to our end users and our clinicians, and as I talk to my peers across the country around how comfortable they are with the systems of today. Very used to it. They've probably worked in it in different organizations they've been in. The standard workflow follows a very similar pattern. And so that muscle memory is now stronger than perhaps it was maybe 5-10 years ago. And so really having the time to look at that core muscle, think about, I have to do this a little bit of a different way, having time for that education, having the attention span for that said education is all something that we're challenged with. We are fighting for attention and time like never before. We live in an extremely busy world, both in terms of the pace of change that technology is happening, but also in the pace of change that people are having in their personal lives. And so how much of that time are we able to capture in a way that's meaningful to really help educate and inform and communicate these changes are coming is a real problem. It's something that we are thinking through in terms of, are there different opportunities to think about just-in-time training? How can we leverage AI to perhaps help teach AI in a different way? And so I think it is at this crossroads of, we have all this great technology advancement. We know we need to change. How do we perhaps advocate for our clinicians to have the time to adopt those technologies? And how do we also have that time to think through, well, this is the technology that we're introducing. We need to tweak it a little bit. We need to modify it a bit so that it really sticks again with the workflow of today.
Well, so how have you gone about addressing these concerns? Like maybe you can give an example or two, and And did it work?
Yes, so we can talk through a couple of different examples. One, we have been very thoughtful of consolidating the type of education and communication that we send out. What really requires communication and education, and perhaps what shouldn't. So to try and curtail the volume again of that type of communication and form. We've also been thinking through what are the 1 or 2, 3 top features that we want to focus in on, and how do we emphasize that through either focused rounding efforts of our support teams and staff. How do we look at those top 2 or 3 technology advancements, and how are we educating the broader organizational leadership on here's where the adoption statistics are. I think those are all viable options. I think the other thing that we currently are struggling with is really thinking about, I'm going to call it consumer analytics, just to use an analogy. So if you think about online shopping experiences today, there's a lot of consumer analytics. And one of the things that we find that we're currently challenged with is really having that equal focus of end user analytics in terms of looking at how are our clinicians interacting with the systems. Not just purely are they using it, but how are they using that said feature in the context of their overall workflow and experience in those systems. And that is an area that I do see that we're lacking, that could help propel us perhaps in a different way. And how do we think of our users in that mindset to think about, if we were to equate that to consumer analytics, what are the different types of tools and analytics that we need to drive those features and make them a little bit more sticky?
Well, let's turn to something you worked on before you came to Mayo, sepsis AI tools. Now, they're not perfect, but they can be helpful. What were the barriers that you have found in that work?
So that's a great story, actually. So we spent months looking at a sepsis AI tool. We studied it, analyzed it, and then it was finally time to roll it out. It rolls out into the practice. I'm out rounding with the organization and leaders, nursing leaders, and I walk across, and there's a nurse that I meet in the ED department. She says to me, "This is great. I love that it's telling me and it's blinking red, but what am I supposed to do with it? Who am I supposed to call? Who am I supposed to engage? And is that person aware that we've now rolled out a sepsis tool? These are the factors that's gone into why the tool is telling me that the patient is potentially at risk for sepsis." And that really struck me hard, because we had thought a lot about the technology and thinking through how to implement the technology, but we didn't think through the operational processes to support that intervention for that particular user group and cohort, in this case, nurses. And so as we were thinking about how does that sepsis AI algorithm impact the overall organization, we noticed that the adoption, again, wasn't necessarily yielding what we were intended, but the more and more we talked, we realized that we hadn't really done a good job of informing of the operational processes that support the implementation of the technology. So again, it's that people side of it that we really didn't think through. So it was a great lesson that I've kind of carried with me as we continue to think through how does adoption work in terms of technology, and what are the different considerations outside of the tech itself that we need to really factor in.
Well, what kind of steps have organizations taken to overcome those barriers?
So one of the things that we're thinking about, and I'll use perhaps ambient as an example right now, is really thinking about the technology as a means by which the practice is changing. And what I mean by that is, how does the interaction from an ambient perspective influence the way that you're taking care of your patient in terms of conversational care? And having a conversation with your patient should be the driver, perhaps, versus having really ambient technology be the driver of conversational care. So we're really trying to flip the narrative in terms of the discussion of how do we think about the process or the outcome that we're looking to solve for, which is increasing, the conversation, informing our patients of their care, and then having that be a byproduct in terms of into ambient documentation and tools.
Well, let's wrap up by talking about a third challenge, like how Mayo is going about implementing ambient AI tools for ambient documentation. It's one of the most exciting innovations I've seen, but how are you going about it at Mayo, and how is it going?
It's going really well, Dr. Lee. It's happening through a number of different ways in terms of thinking about some of the topics we've already talked about. We're seeing a lot of organic excitement, especially from our provider user base. There is a lot of excitement in using these tools. We have anecdotal stories of how our clinicians have had time now to dedicate more towards things that they want to do, saving them pajama time, et cetera. So from that standpoint, in terms of some of the things that we talked about earlier, in terms of organic change management, influence in terms of individuals, I think it's been going very well. We've also, from a nursing perspective, really wanted to ensure that we were engaging with vendors that wanted to co-create with us, for nurses, by nurses. And so we've embarked on a journey with a vendor to really co-create what the ambient documentation tool, ambient listening documentation tool of the future would look like. And so we are moving further upstream in terms of the product life cycle to ensure that our clinicians are at the forefront of developing these tools. You know, I remember when we were implementing these clinical systems, EHR systems, the guiding principle was involve your clinicians early in the implementation cycle. Well, now we're really thinking about, well, I think it's even that might be a little bit too late. How do we get our frontline or our bedside clinicians further upstream into the development of these tools so that it is easier to adopt when the technology is ready to be implemented? So lots of great lessons that we are applying that we've learned in the past into how this technology is rolling out for the future.
Well, let me bring up one final thing from a social gathering I was part of, 2 weekends ago, a meeting of our book club, and there were 2 other physicians there. And I was talking about how I love ambient AI, and that I found that now I don't worry about forgetting things. And I didn't even realize before that I was being a little bit drained by always worrying about messing up and forgetting the fourth of the 4 things I said I was going to do for the patient. And I was talking about how much I love ambient AI. But these 2 other wonderful physicians, really wonderful physicians, they had not even tried it yet, even though they were eligible. They all they had to do was send an email and they would get registered for it. What would you say to them? They clearly felt a little intimidated by trying something new. They felt like they didn't have time to learn how to use it. Even though I told them it takes about 3 minutes to learn how to use it. What would you have said to them if you were at our book club dinner that night?
I would have probably actually turned the table right back at you, Dr. Lee, to be honest. I would have said, Dr. Lee, can you share a little bit more about the impact it's had on your life in terms of also your well-being? Because I do feel that is what we see as driving the clear momentum. So when we're rolling this technology, specifically ambient technology, out to our organizational groups, we find these 1 or 2 stories to be highly impactful. There's one thing for me to come and say that in terms of from my role and from my vantage point, but at the end of the day, there's nothing like that peer-to-peer guidance and impact that really resonates with someone. So to be able to have them speak on behalf of that technology, give them real world scenarios, tell them what the impact has been, there's nothing that equates to that. I also think the other thing I would probably add would be how much data can we help to to perhaps give them or empower them with, hey, this is the way you're using the system today. This is what it might look like if you were to use the system tomorrow, I think is one other tactic. And then we could, there's always the opportunity for potential out the elbow support or different types of support. But to your point, this technology is pretty easy to learn in terms of the 3 minutes. It's that little extra push that's needed to say, can I just try it? I think the other thing that I've found very impactful for adoption in this particular case has also been the experience of our patients. We find that our patients are looking for this type of technology, and they find great value in it as well. So it's that combination of peer-to-peer support, data, and also the impact on patient experience that I think is what I would say.
Well, I took my iPhone out and showed them at dinner, and you can imagine this is why I don't get invited to very many dinner parties. But I felt better even if they didn't. Well, anyway, thank you so much, Edwina. I know you're not going to be the last Chief Clinical Systems and Informatics Officer, and I'm so grateful to you for sharing the nature of the work that is the focus of your new role. I know other organizations are going to be interested and realize that they could benefit too. They're probably doing it already, although not perhaps as effectively and with as much focus as you're doing. I will be very interested in staying in touch and for you to share more insights as you help implement other kinds of innovations at Mayo. So thank you, and look forward to talking more.
Thank you.